You need to ask Senator Burke questions pertaining to him directly. Now, back to the bill. On Medicaid expansion and reform, this bill explicitly authorizes the Department of Medicaid to expand coverage. It appropriates approximately $500 billion in federal dollars for FY14 and $1.8 billion for FY15. It includes a circuit breaker that would automatically roll back expansion if federal funds change from current law. These are the only provisions that are similar, really, to any other bill. It caps cost growth as measured every 6 months at no more than the increase in medical CPI as calculated on the preceding 3 years. The cap is per eligibility group, Medicaid service, and recipient acuity level. It reduces the relative number of individuals enrolled in Medicaid by transitioning more people into employer-sponsored insurance plans or the health insurance marketplace. I want to emphasize the fact that this bill explicitly prohibits that these reductions occur through restricting eligibility levels. It reduces the nursing facility Medicaid payment rate if residents utilize emergency services or have hospital admissions rates that are above the average. It promotes a reduction in health disparities amongst minority populations, ensures that care is delivered in a linguistically and culturally competent manner, and promotes the reduction in abuse of substances, including illegal narcotics, alcohol, and tobacco. Furthermore, it grants authority to the Department of Medicaid to establish standards for telehealth services, reimbursement defined as healthcare services delivered to a patient through the use of interactive, audio, video, or other telecommunications or electronic technology from a site other than the site where the patient is located. On the matter of legislative oversight, it creates a committee called the Joint Medicaid Oversight Committee, or JMOC. This will serve both as an oversight and innovation function through the review of rules, waivers, and the Medicaid program. JMOC will also make recommendations for changes to the General Assembly. All Medicaid rules and waivers must be filed with JMOC. JMOC can review and offer opinions to the rules, but does not have veto power, nor does it replace JCAR. JMOC shall prepare a report by January 1st, 2014, with recommendations for legislation regarding payment rates for Medicaid services. The goal of the recommendations is to provide the state Medicaid director statutory authority to implement innovative methodologies for setting Medicaid payment rates that limit the growth in cost and also protect and establish guiding principles for Medicaid providers and recipients. Finally, in the area of workforce development, JMOC, the Department of Job and Family Services, and the State Department of Medicaid shall study ways to improve the Medicaid program's coordination with workforce development programs and prepare a report by June 30th, 2014. The Department of Medicaid shall also establish a managed care case management program for people that are nearing the 138% income level so they can gain access to and maintain optimal employment opportunities. And finally, they would gather data in the Medicaid transition population's utilization of the workforce development program. Now, I want to give you guys a little bit of background. I know this is a lot of information, and I'm actually going to embark into the part of my presentation which is actually even more detailed than what I just gave you. In our previous bipartisan discussions, which I referenced, we engaged the Health Policy Institute of Ohio, or HPIO, and Ohio State to run various models to ascertain if it was possible to cover more people while saving the state money. These models assumed that current spending growth rate of 7.2% in Medicaid without any additional lives covered through expansion. They also assumed that medical CPI has been hovering around 3.5 to 4%, which is how those percentages were chosen. And this is likely what would be the 3-year rolling average number that I earlier referenced. Then they tried to look at what would the spending amounts be for the Medicaid program under both the current growth rate of 7.2% without expansion compared to slowing the spending growth rate to 3.5% with a 1% increase for population uptake, which totals 4.5%, and including the additional expansion population. What this yielded, it showed that starting in 2014, both the state share and the aggregate per member per month cost, which is how much it costs for an individual that is enrolled in Medicaid to receive services, is actually lower under the expansion scenario. The state share in 2014 in billions without expansion is 7.94. The state share in 2014 with expansion is 7.78. The PMPM in 2014 without expansion is $666.72. The PMPM in 2014 with expansion is $626.72. Now, this may seem like a very small difference, but this gap gets larger between the two as time passes. So then they modeled the big question that I think many naysayers are fixated on. What happens if the federal government walks away? What if the current 60-40 federal-state cost-sharing structures return instead of the Affordable Care Act enhanced match, and the expansion population is still going to be covered? So they looked at the 3.5% growth rate plus the 1% population growth rate in that context. And what do they find? In 2021, state share is still less with the expansion population, aka more people, than it would be at the baseline growth rate of 7.2% without expansion, aka no new people except for current population growth. As a matter of fact, in all scenarios except for one, the expansion state share is less than the baseline non-expansion amount. This worst-case scenario is if the state-federal match returned to a 60-40 split in 2017. Only in year 2017 would the state share exceed the baseline non-expansion state share amount in the above circumstances at a 4.5% growth